Tanya Dorff from City of Hope, and we're here at the Uromigos Live conference in Nashville. I'm pleased to be here with my good friend and colleague Neeraj Agarwal, who's professor at Huntsman Cancer Institute at University of Utah, and we're going to be talking about the TALAPRO-2 study.
And it's a pleasure to be here.
So set the stage for us, if you will. How was Talazoparib studied in prostate cancer previously, and what were the goals of the TALAPRO-2 study?
Yes, so Talazoparib, as we know, is a PARP inhibitor, has been tested in a 100-plus patient trial. This was a single-arm study in heavily pretreated patient populations. Of these patients had metastatic CRPC who had received treatment with one or two taxane therapies and had to have progression on a novel hormonal therapy such as enzalutamide or abiraterone or both. And this study, which was published in Lancet Oncology in 2021 by Dr. Johan de Mono and team, showed robust activity of single-agent Talazoparib in this patient population who had homologous recombination repair mutations. The median progression-free survival in all this cohort was about 6 months, but remarkably, patients with BRCA1 and BRCA2 mutations had a median PFS of 11 months. I think this study paved the way for future studies of Talazoparib, especially in the combination with enzalutamide in the TALAPRO-2 phase 3 trial.
Right, so what were the final results as published in the Lancet for the primary endpoints, progression-free survival and overall survival?
Yes, so this was a large phase 3 trial. There are two distinct cohorts in this trial. The first paper, which got published in Lancet, reports on the all-comer patient population, about 800 patients. And this second cohort is an additional 279 patients who were selected or who were recruited based on the presence of homologous recombination repair mutations. And if you combine these patients who had HRR positivity in the all-comer patient population, about 179 patients, and then additional 230 patients which were recruited because they had HRR mutations. So we have two distinct cohorts. One is all-comer cohort, and then another is the HRR mutation positive patients, there were like 400 patients combined, both these groups.
So the genomics were known at study entry and the analysis was stratified for this?
Yes. So let's talk about the publication which has already come up, which I presented earlier this year in the GU-ASCO meeting, and which led to approval of Talazoparib enzalutamide combination for patients with CRPC, metastatic CRPC with homologous recombination repair mutations. So in this all-comer patient population, radiographic progression-free survival was the primary endpoint, and key secondary endpoints for overall survival and response rates, time to chemotherapy, time to PSA progression, multiple endpoints which are pertinent to clinical practitioners and patients, and quality of life. So if you look at the primary endpoint of radiographic progression-free survival, there was a 37% improvement or reduction in risk of progression or death in the combination arm of enzalutamide plus Talazoparib versus enzalutamide plus placebo. If you look at specifically those patients who had homologous recombination repair mutations in this all-comer population, there was a 55% reduction in risk of progression or death. If you look at those patient population or those patients who were HRR mutation negative based on prospective tumor tissue testing, there was a 34% reduction in risk of progression or death. So overall, trial met the primary endpoint of reduction in risk of progression. And specifically, if you look at the patient who had homologous recombination repair mutations, and based on 55% reduction in risk of death or progression in those patients, the combination is so far approved for patients with mCRPC with HRR mutations.
So significant benefit, particularly in that biomarker-selected population. What about the toxicities? How did patients handle the treatment in combination?
Yes. So before I talk about toxicity, I'd like to highlight a few other clinically relevant endpoints which were seen in this, and I'll focus on HRR mutation positive patients for now, because that is the FDA approval, and we are really hoping that with due course of time, we will see favorable efficacy and toxicity profile. But for now, let's talk about the clinically relevant endpoints, which are all pre-specified endpoints in the HRR mutation positive patients. There was if you look at time to PSA progression, for example, the time to PSA progression was 11 months in the enzalutamide cohort, enzalutamide only cohort, and it was 27 months in the combination cohort, which received enzalutamide plus talazoparib. If you look at time to cytotoxic chemotherapy use, time to progression on subsequent therapy, and even all those endpoints were significantly favoring the talazoparib arm, talazoparib plus enzalutamide arm. If you look at overall survival benefit, obviously the data are immature right now with the number of events have not been met, but hazard ratio is 0.69. So it's trending strongly in the favor of talazoparib plus enzalutamide in the HRR mutation patients.